Hello everyone. Today we'll be talking about how does the minute ventilation changes your alveolar ventilation. If you got a tidal volume of 500 cc's, around 150 cc's will remain in your anatomical dead space and rest of it will go to alveolar ventilation. In a normal person, you do not have a dead space, so around 350 cc's will participate in your gas exchange. And understand that this alveolar ventilation is what is required to improve your carbon dioxide levels in the blood. Minute ventilation is nothing but tidal volume into your respiratory rates. If you're breathing at 10 times a minute, your minute ventilation is 5 liters per minute. And out of 5 liters, around 1.5 liters are going to go into anatomical dead space and 3.5 liters are going to alveolar ventilation. If you have alveolar dead space, say for example 100 cc's, and your tidal volumes remains at 500, your alveolar ventilation is going to drop. The amount of air that is going to remove the carbon dioxide from the alveoli to the outside decreases. This is the ventilation that you are most interested in when you want to improve your carbon dioxide levels. So in this case, your minute ventilation remains 5 liters per minute. However, 1.5 is still going to your anatomical dead space, and now 1 liters per minute going to alveolar dead space, and only 2.5 liters per minute are going to alveolar ventilation. So if you are dealing with dead space, to reduce the carbon dioxide levels in the system, you have to increase the alveolar ventilation, or you can decrease the amount of dead space. To increase the alveolar ventilation, you can only do it by two ways. Either you can increase the respiratory rates or you can increase the tidal volumes. So let's see how these two parameters affect your alveolar ventilation. We have a person with tidal volume of 0.5 liters, respiratory rate of 10, which gives you minute ventilation of 5. And out of 5, if your anatomical dead space is 150 cc's, your alveolar ventilation is 3.5 liters per minute and your dead space ventilation is 1.5 liters per minute. If you're a person with a dead space, say for example 100 cc's, and he's still taking tidal volume of 0.5 liters, to maintain the alveolar ventilation of 3.5 liters, he has to generate a respiratory rate of 14 times a minute and has a minute ventilation of 7. You are breathing at a faster rate to achieve the same alveolar ventilation to maintain the PaCO2 when you have dead space. If you double up the minute ventilation, so let's say from 5 to 10 liters per minute, your alveolar ventilation also doubles up to 7 and your dead space ventilation also doubles up to 3 liters per minute. Let's see what happens when we double up the minute ventilation in patient with your alveolar dead space. This patient was breathing at 7 liters per minute at baseline, and now he's breathing at 14 liters per minute. And out of 14, 7 liters per minute goes towards alveolar, and proportionately, there is a 7 liters per minute that goes towards dead space ventilation. So if you have no alveolar dead space, whenever you double the respiratory rates, that means 100% increase, you will have 100% increase in both alveolar ventilation and dead space ventilation. If you are dealing with alveolar dead space, doubling the respiratory rate will still increase both your alveolar ventilation and dead space by 100%. Increasing the respiratory rate increases both alveolar ventilation and dead space ventilation proportionately. However, one of the things that you have to remember is when you increase the respiratory rate, you're going to decrease the expiratory times. And if you have alveoli with long time constants, such as in COPD, you can start air trapping. And when you have air trapping on top of your dead space, your alveolar dead space can increase further and it can decrease your alveolar ventilation. In this, we'll change the tidal volume. So if you have a person with alveolar dead space of 100 cc's, to achieve the same level of alveolar ventilation, keeping respiratory rate constant, he has to take a tidal volume of 0.6 liters to maintain his carbon dioxide levels. So out of 6 liters per minute of minute ventilation, 3.5 goes towards alveolar and 2.5 goes towards dead space. These patients with alveolar dead space have to breathe at a higher tidal volume to achieve the same degree of alveolar ventilation to maintain the PaCO2. If you double the minute ventilation in this case by doubling the tidal volume, your alveolar ventilation increases more than double. So instead of 3.5 going to 7, their alveolar ventilation is now 8.5, and your dead space actually remains the same, because even if you have increased the tidal volume, your anatomical dead space has not changed. If you're dealing with alveolar dead space and you double up the minute ventilation, proportionately you will have more of that ventilation going to the alveolar dead space as well. So 16% of the tidal volume is going to go towards alveolar dead space. So in this case, it will increase to around 233 cc's. Your alveolar ventilation has certainly increased, though not to the same degree as you would see person without any alveolar dead space. And your dead space ventilation has also increased by at least 1.3 liters per minute. So in a normal person, doubling the tidal volume, around all the increase in the minute ventilation goes towards the alveolar ventilation, and 0% of it goes towards the dead space. While if you're dealing with alveolar dead space, in this case, 78% has gone towards alveolar ventilation and 22% has gone towards the dead space ventilation. And this percent will depend upon what's your alveolar dead space fraction. So increasing the tidal volume would appear not to increase the dead space ventilation to a similar degree when compared to the respiratory rates. However, in COPD, when you increase the tidal volume, proportionately more air will go towards the dead space, as these alveoli or the bullae are less stiff, and this can worsen air trapping. So watch out for increasing tidal volume in COPD patient. In summary, if you double the respiratory rate in patient with no alveolar dead space, alveolar ventilation improves by 100% and your anatomical dead space also increases by 100%. Similarly, in patient with alveolar dead space, your alveolar ventilation, anatomical and alveolar dead space ventilation, they all increase by 100%. However, when you double the tidal volume, in a normal person, your alveolar ventilation increases by 142%, and in patients with alveolar dead space, it increases by 134%. There is no increase in anatomical dead space ventilation, and there is an increase of 52% in alveolar dead space ventilation. So, increasing tidal volume has more impact on alveolar ventilation than the respiratory rate. Therefore, in patients with ARDS, when you use the low tidal volume ventilation, drop in alveolar ventilation can be much higher than drop in minute ventilation. And these patients can have hypercapnia issues. However, in these patients, we know that higher tidal volume increases the mortality. So use the respiratory rate to counter hypercapnia in patients with ARDS on low tidal volume ventilation. In COPD patients, increasing the respiratory rate can increase alveolar dead space due to air trapping. Similarly, increasing tidal volume can also increase the alveolar dead space in these patients. So always look out for auto PEEP in COPD patients when you are increasing the rates or tidal volumes. Though tempting, higher tidal volumes do not always increase the alveolar ventilation as you want and can cause worse outcomes, especially in ARDS. So always look at the risk and benefit before changing tidal volumes or the respiratory rates. Understand what pathology are you dealing with. Takeaway points from this lecture are, when you change the minute ventilation, the alveolar ventilation will change depending on alveolar dead space fraction. You may not get the proportionate decrease in the PaCO2 as you would expect when you have increased minute ventilation and you have alveolar dead space to deal with. Changing minute ventilation will have different effect on alveolar ventilation depending on whether you change the respiratory rates or tidal volumes. So understand the difference between the minute ventilation and alveolar ventilation. Bottom line is, alveolar ventilation is the one which drives your CO2. Minute ventilation is simply a surrogate of this. Thank you.